Hi everyone, and like Cynthia said, I'm here to present Pioneer, which I haven't put up there, but it stands for Precision and Expert Radiotherapy, which is a project we undertook at the Northern Sydney Cancer Centre to explore a way of improving the palliative patient journey in radiation oncology. So a little bit of background. Radiotherapy has an important role in providing the symptomatic relief and overall improvement in the quality of life for patients with bony and soft tissue metastases. The current clinical pathway for radiotherapy, as you can see here, involves firstly getting a referral to radiation oncology, then coming in for a consult with a radiation oncologist, and then returning for a CT simulation scan. And this CT is purely used for treatment planning purposes. And after these initial procedures are done, patients can wait up to 2 to 3 weeks before they actually receive their treatment. And as this is where an individualised treatment plan is produced. So has this issue been addressed? Not really. The current research out there is aimed at the implementation of a fast-track program or a rapid access clinic where patients for palliative radiotherapy have a same-day consultation with a large multidisciplinary team. This has reduced the multiple hospital visits, but it has not eliminated the wait time from initial diagnosis to the patient receiving their treatment. This delay is not only burdensome for the patient, but also for their families and caregivers, and results in unnecessary, prolonged discomfort and reduced quality of life. So at the NSCC, we have instituted a clinical pathway to allow treatment of selected palliative patients without simulation CT. Ultimately, our aim was to explore how we could streamline symptom resolution for our palliative patients, patients whose comfort is, above all else, our priority. This talk will identify key factors in this pathway and areas which we have identified that need further work. So to see if this was at all feasible, this project was broken up into a 2-stage process. In stage 1, we first undertook a retrospective review of palliative radiation treatments from our database to help us define which patients would be most suitable. Patients had to be manually filtered to see if they had diagnostic CTs available, and we ended up looking at 117 patients previously treated in our department. We reviewed the quality of their diagnostic imaging. We looked at the diagnostic field of view, differences in patient position, and other potential factors which would impact radiation dose if the CT simulation was not acquired. From this, a palliative patient criterion was created for this clinical pathway. So in stage 2, we aimed to improve image fusion. And to put this more simply, we wanted to know if we could reproduce a patient's diagnostic CT position. This was the prospective part of the project where patients for palliative intent treatment were screened and had their diagnostic CTs imported into our treatment planning system. They were then reviewed to see if the patient was applicable for this clinical pathway, and the patients were then called in, had their CT simulation as per our department protocol, but we set them up to best replicate the diagnostic CT position. In doing so, this allowed for better plan comparison. So here are some of our results. From stage 1, suitable areas were limited to the abdomen, chest, lumbar and thoracic spine, the pelvis and sacrum. Areas such as the cervical spine and extremities were excluded. Take, for example, the cervical spine. Replication of the neck flexion and extension was quite difficult to reproduce. And areas such as the extremities also posed an issue of positional mobility, and lesions in these areas also were accompanied by 2D X-ray images, which we can't use for treatment planning. We also encountered issues with diagnostic CT. We also encountered many issues with diagnostic CT planning, the main one being field of view. For treatment planning, we need the whole body contour in the CT scan, and a majority of the diagnostic scans had a smaller or incomplete field of view. This is normal practice for diagnostic radiographers as it increases the resolution of the diagnostic CT to visualise the area of interest better. So this didn't mean that we couldn't use these images. This meant we just had to be more selective with the placement of treatment beams. We found that PET CTs were the best diagnostic images to use as they always encompassed the whole patient body, but it also, because of the PET part, enabled us easy location of lesions. The best sites for simple palliative radiation without CT simulation were the lower thoracic, lumbar and sacral spine and the pelvis. In these locations, there was no significant difference in dose calculation between the diagnostic and the CT simulation, as these areas have now been incorporated into our standard clinical care path. However, caution was noted if the radiation entered through air cavities such as the lung, so patients with lesions in or close to lung are not currently suitable to be treated without simulation. As we've noted, there's a dose error of up to 5%. This is a future project which will need input from our radiation oncologist regarding if this 5% error does have clinical impact. So the implications and future direction. For palliative intent treatments, we have successfully produced clinical acceptable plans using a patient's diagnostic CT, and we've been able to replicate the diagnostic position for treatment. At this current stage, like I've mentioned, we've removed the need for simulation CT from the clinical pathway for patients with bony metastases in the lower thoracic spine, lumbar spine, sacral spine, and the pelvis. This has enabled us to have a plan available at the patient's initial consult with their radiation oncologist. As such, treatment on the same day as their initial consultation or soon afterwards can be facilitated with minimal impact on the radiation department and workforce. We are currently conducting timing studies to evaluate the implementation of this palliative clinical pathway, but it has major implications for improving the care of patients with metastatic cancer. The significance of this project is made clear to you. We can think for a moment. Consider the pressing needs of the palliative population. To wait several weeks for a treatment is too long. This precious time can be spent in relative comfort, and as radiation therapists, we are obligated to develop and deliver care that is considerate of the need to expedite quality of life for these people. Any questions?
Thank you. Is there a time frame for the CT scan as to which we can, when we can use it? So if it's, for example, 4 weeks old, is this something we can use, or should it be recent enough just to be used?
Yes, so we had a discussion with all our radiation oncologists and we came with a time frame of 4 weeks for it to be clinically usable. So anything that went outside was up to the radiation oncologist discretion.
And also I'd like to ask, so what is, in terms of just saving time for the patient, how much time does it save for the patient?
Well, like I said, they can have a plan available when they come in for their consult with their radiation oncologist. So they can see the the doctor in the morning and have their treatment a couple hours after.
Right, so it's reducing wait times and
Yes.
time for the patient.
Yep.
Yeah, fantastic. Thank you, Shelley.
Thank you.
Yeah, thank you.